So my name is Dr. Vlasis Ninios. I'm a consultant interventional cardiologist based in Interbalkan Medical Center in Thessaloniki, Greece. And today I'm going to talk to you about the late-breaking trial, the one-year outcomes of the early feasibility study of the AltaValve. So the limitations currently about the existing TMVR technologies is the higher rejection rate of the possible candidates that exceeds 70% in most of the series. The reason for that is the narrow LVOT, the presence of mitral annular calcification, and the size of the mitral annulus. And that is limiting how many patients can be eligible for the therapy. So the AltaValve system is a unique atrial fixation system. The system conforms against the left atrial wall, and the valve itself is positioned in the center of the implant, so it's supraannular, and this way it doesn't affect the left ventricular outflow tract at all. It has a wide size matrix, so it can accommodate sizes up to 50-51 millimeters, so even big annuli can be addressed. And it's a soft outer frame that conforms against the mitral anatomy. So this way, when it interacts very favorably with MAC, with mitral annular calcification. So all three limitations are actually addressed quite nicely by that system. So the early feasibility AltaValve study was a multicenter prospective study conducted in multiple centers in US, Europe, and Japan. The entry criteria was severe symptomatic mitral regurgitation, and the patients should not be eligible for surgery, so high risk for surgery. The study was conducted initially as a transapical approach, but then moved to a transseptal approach using the current system, was a 29 French transseptal system, and was achieved a recruitment of 30 patients in total. So the key findings is the broad applicability. 77% of the patients screened were accepted, which is unique. We have said earlier that the rejection rate is about more than 70%, so 77% acceptance rate is really high and unique. It was a safe procedure, so 30-day mortality was low, and 1-year mortality in the cardiac mortality in the transseptal cohort was 0%. The patient population treated were mainly female patients with preserved ejection fraction, and that shows that the ventricles were small. That means the LVOTs were narrow, and therefore the reason behind it because the trial recruited most of the patients rejected by other technologies. The success rate was achieved in 97% of the patients. There was only one patient needed to be operated at the very early part of the experience, and there were no evidence of early valve failure, thrombosis, need for reintervention, strokes, or pacemaker implantation. So overall, it was a demonstration of safety and efficacy in this population. So we have a good signal of safety and efficacy, but the most important thing is the broad applicability of the product. So the clinical implication is now that we're moving into the pivotal trial, which is a large multicenter trial, hopefully the product will demonstrate this in a larger scale, and therefore that creates the basis of having a therapy that can be broadly applicable, safe and effective in a wide range of patients that currently cannot be treated either with surgery or transcatheter atrial repair. So the key take-home message is as the pivotal trial progresses, we have hopes that this device can address most of the pathologies, including MAC, including functional atrial or ventricular MR or primary degenerative MR, in a safe and effective manner. And hopefully this could create a new gold standard for the therapy of mitral regurgitation.